There are multiple ways to look for these, and the surest way is to do a tumor biopsy, and there are multiple methods for ALK. There's IHC, there's FISH, and there's next generation sequencing, and they can all detect it, although next generation sequencing by itself can have its problems. For ROS1, similarly, there's FISH, and there's also next generation sequencing. The other option, and what often happens, is sometimes we can't biopsy these. We can't get a good lesion to biopsy. It's in a bone, and if it's in a bone, you can't do molecular testing. We do blood-based testing, and blood-based testing can be very effective. However, how you interpret blood-based testing is very important. So when you do your standard blood-based testing, whether it's a Guardant 360 or a Foundation, they do two things. One is they do sequencing of the of the DNA in the blood. They also do something called fusion capture, which is very inefficient. So it is not uncommon if you do a blood-based test to get a report that may even have a mutation in your gene, such as ALK or ROS1, but does not report the ALK or ROS1 fusion, and that causes confusion in doctors in the community. So you cannot depend on a blood-based test to tell you that it has an ALK translocation or ROS1. However, once you already know it's there, they never go away. If it's negative in a blood-based test, what you're using that blood-based test for is to look for second site mutations. And so that's often a source of confusion, so both are useful, but you have to know how to interpret a blood-based test. And I've had several patients referred to me who were told that they had lost their ALK translocation or their ROS1, and it's simply a failure of the fusion capture while the sequencing's fine. And what you're using those tests for is to sequence either the ALK gene or the ROS1 gene for second site mutations so we can pick the right drugs to treat them with.